Meet Eric. He's 69 years old, a retired engineer, and over the past few weeks, he's been feeling unusually tired and unwell. His wife has noticed a swelling on the right side of his neck, and she's worried. Eric visits his GP. The doctor finds a hard, non-tender lymph node, approximately 3 centimeters in size, on the right side of his neck. It is fixed to the underlying tissue and cannot be moved freely. The differential diagnoses include local infection of the mouth, throat, or ear, malignancy, such as lymphoma or carcinoma, and inflammatory conditions, such as sarcoidosis. 3 findings raise strong suspicion of malignancy. The node is hard, it is non-tender, and it is fixed. Its size of 3 centimeters, exceeding the 2 centimeter threshold, reinforces the concern. The doctor asks about the so-called B symptoms, 3 classic warning signs in lymphoma. Unintentional weight loss of more than 10% over 6 months, drenching night sweats requiring a change of sheets, and unexplained fever above 38 degrees Celsius. Eric has all 3. Eric is referred through a fast-track cancer pathway. The ENT specialist performs a fine needle aspiration, but the result shows only lymphocytic cells, not carcinoma. That's not enough. The next step is excision of the entire lymph node for histological examination. The result comes back: Diffuse Large B-Cell Lymphoma, abbreviated DLBCL. This is the most common subtype of non-Hodgkin lymphoma. Eric is referred to a hematology department. Enlarged lymph nodes are found on both sides of the neck, in both axillae, and in both inguinal regions. A large, hard mass is palpated in the abdomen. A PET-CT scan and bone marrow biopsy are ordered. The bone marrow shows 40% infiltration by DLBCL. Eric is classified as an Arbor stage 4B with bulky disease, meaning widespread disease on both sides of the diaphragm, bone marrow involvement, and B symptoms. The treatment is R-CHOP chemotherapy, a combination of 5 agents. R for rituximab, a monoclonal antibody targeting B cells. C for cyclophosphamide, a cytotoxic agent that damages DNA. H for hydroxydonorubicin, inhibits DNA replication. O for oncovin, also known as vincristine, halts cell division. P for prednisolone, suppresses inflammation. The goal is cure. Approximately 50 to 60% of patients achieve complete remission with first-line R-CHOP, even at stage 4. The day after the first cycle of chemotherapy, Eric becomes seriously unwell. His wife calls the ward. He is dizzy, nauseous, and collapsed in the bathroom. Blood tests reveal hyperkalemia, hypocalcemia, hyperphosphatemia, hyperuricemia, and elevated creatinine. The diagnosis is Tumour lysis syndrome, a serious complication in which chemotherapy destroys so many cancer cells at once that their contents flood the bloodstream. It is particularly common with aggressive tumors that have high chemosensitivity and a large tumor burden. Treatment includes aggressive intravenous fluid therapy of 3 to 4 liters, allopurinol, electrolyte correction, and dialysis if necessary. 2 days later, at 2 in the morning, Eric suddenly develops severe abdominal pain. He has rebound tenderness and guarding on palpation. An emergency CT abdomen is ordered. Finding: perforated hollow viscus. The large abdominal tumor mass has increased the risk of perforation, a rare but life-threatening complication of bulky lymphoma during treatment. Eric completes all 6 cycles of R-CHOP and achieves complete remission. He is followed up for 5 years and discharged from the department. But 6 years after discharge, he is re-referred. His hemoglobin has been slowly falling, with no B symptoms. The suspicion is therapy-related myelodysplastic syndrome, a late complication of chemotherapy in which the treatment has damaged the bone marrow. Diagnosis is made by bone marrow biopsy with chromosomal analysis. Let's summarize Eric's case. Enlarged lymph node. Biopsy. DLBCL diagnosis. Ann Arbor stage 4. R-CHOP treatment. Tumour lysis syndrome. Perforated viscous. Complete remission. Late complication, MDS. DLBCL is potentially curable even in advanced disease, but requires close monitoring for both acute and late complications. Remember, B symptoms, hard fixed lymph node, and Arbor staging are the key concepts.